I didn't unmute, y'all. I'm gonna have to redo that. Hey everyone, welcome to Zoom conference. Please join via poll EV, and we will do some questions throughout the conference. So another IM Basics conference for some of our senior residents. This may seem like, oh, this is really easy, but I think it's always helpful to go back through even our easier conferences and develop really strong illness scripts, which is what I'm always harping on, and then really strong clinical reasoning for conditions that we see really commonly. So today we're going to be talking about cirrhosis, and our objectives today are to define it and to think about the diagnostic criteria, look at some standard of care for complications related to cirrhosis, and then some inpatient management referrals. So first, like we always do, just a primer for the talk today. Which organ do you guys think in this CT scan slice is abnormal? I heard someone say it. The liver. And why do you think that it's abnormal? It looks lumpy. Maybe it looks a little big. Okay. Anybody else? Any other abnormalities that you're seeing? What do you think? What makes the spleen look weird or different to you, Dominic? Are you talking about this thing?
Yeah.
I think that's just an artifact.
Okay.
Yeah. Good, yeah, so the correct answer is the liver here. And so in this image, the rest of the organs are the spleen here. And you're right, usually it is supposed to be more of a crescent-shaped organ, so in this patient it may be enlarged. Here's the fluid-filled stomach. Here's the contrast-filled aorta. And then the liver, which is abnormal. The surface of the liver on a CT scan should be really very uniform, and so these notches are abnormal, and so this person has a nodular liver. Okay, so for our case today, we have a 62-year-old man who's admitted with abdominal pain and found to have really large ascites, and so the ED wants to admit them to you. He has a history of hepatitis C. He's tried treatment twice. The first time he failed treatment and had positive viral load, and then the second time he had to stop treatment early due to an admission related to alcohol intoxication. Today he reports that his last drink was 2 years ago, but before that he was a pretty heavy drinker for 30 years. In the rest of his review of systems, he reports some poor sleep. He feels like he's forgetting things, but denies any fevers or chills or any other symptoms. And then at home, he's on Lasix 20, tamsulosin, omeprazole, and then propranolol. And so just based on that information, what other questions would you like to ask this patient? So I can go back to it. Any skin discoloration? Yeah, so he says he's a darker skinned gentleman, and so he says he hasn't really noticed that. Say again? Oh, GI bleed symptoms. Yeah, no, he denies he has not had any melena. He denies any vomiting, blood, no GI bleed symptoms. Yeah, he says that over the last week, he feels like if he lays flat, he gets a little short of breath, and then when he walks, he gets short of breath. No, he's never been told he has kidney or heart problems. He says he sees some soft lines at the ankles, but doesn't really think his legs are very swollen. His belly feels very swollen.
Diarrhea?
No diarrhea. Has he ever had fluid accumulation? Yeah. So he tells you that he actually was told that he has cirrhosis, and 5 years ago he thinks that somebody drained his belly, but since then he's been fine. Anybody else? Anything else? I think those are really great questions. You guys are getting at making sure that we're thinking of other etiologies of his ascites. Like I think you were getting at heart and kidney disease, which can cause ascites. And you guys are just getting at sort of how acutely we may treat this person. Will someone get the door? And then Amanda, in the ROS, we said that he denied any fevers or chills. Great. Okay, so here's his exam. He has pretty normal vital signs. He has thin extremities, positive icterus, some edema that you noted on your exam. His heart exam is pretty normal. Lung exam, normal. He does have a fluid wave. And then he has some sequela of cirrhosis like caput medusae, telangiectasias, and palmar erythema. But you know, no asterisks on his neuro exam. Is this exam what you guys would have expected for this patient? Is this exam what you would have expected for this patient? Yeah, most people are agreeing. Yeah, so we're suspicious already that he has cirrhosis, and so making sure that you do an exam that's consistent with somebody that has cirrhosis. So looking for some of these sequela. You know, I think Colton asked about jaundice, and so sometimes you'll see scarlet icterus as the first sign of hyperbilirubinemia, and then the skin color changes, I've noted, come somewhat later in the patients. Here are his labs, and I'll let you guys take a look at those. And then tell me what jumps out at you. His bilirubin is 4.
Okay,
there you go. INR is elevated. Colton, what about the ALT? The ALP, yep. ALP is elevated. Thrombocytopenia, yep. Platelets of 57.
Something that, like, you see that this guy, and you expect, like, you know, it's normal that he has not super elevated,
Yeah, so you're saying, so I noted that here, so it's common to see what looked like normal AST and ALT in patients with cirrhosis because their hepatocytes are now so damaged that they can't even spill these enzymes, and so so don't think that this patient doesn't have advanced liver disease because those are normal. So good, great, thank you for pointing that out. And a little bit of hyponatremia, yeah. Mm-hmm. Okay, so little epidemiology here. What are the top 3 causes of cirrhosis in the United States? Alcohol, fatty liver disease, Hep C, yep. So great. It's estimated conservatively that about 1 in 500 people in the United States have cirrhosis. Some, of course, are undiagnosed. And then the most common are Hep C, alcoholic liver disease, the combination of the two, and then now rising higher and higher is non-alcoholic fatty liver disease, which can progress to cirrhosis. Cool. So then how do we make the diagnosis of cirrhosis? And when I was making this talk, I asked myself that question and wasn't sure I knew the answer because we just accept that somebody has cirrhosis a lot of the times. And so biopsy is really the gold standard, of course, to diagnose cirrhosis, but not everybody needs it. And so here's why. Because if on history and exam, a patient has pretty consistent findings like ascites, which has a likelihood ratio of 7. So in this patient already, your post-test probability that he has cirrhosis has jumped even higher, right? Some history of fatigue, anorexia, jaundice, hyperestrogen state, which in men presents with gynecomastia sometimes, and then caput and splenomegaly, which are portal hypertension findings. Then on labs, often we see thrombocytopenia, which has a likelihood ratio of 6.3. So again, with this patient, your post-test probability goes even higher. Hyperbilirubinemia, elevated alkalis, hyponatremia, all of which we saw in his labs, which are quite common in patients with cirrhosis. And then imaging findings wise, ultrasound is used most often to diagnose cirrhosis. That has a sensitivity of 91%, which means that everyone that 91% of people that don't have cirrhosis have a normal exam. So if you have a normal exam, you can be quite certain that they probably don't have cirrhosis. And then if you guys have ever heard of a fibroscan, which is a fancier ultrasound that looks for the degree of fibrosis in the liver, CT can be used often, and we saw an earlier example of what a nodular liver may look like on CT scan. And then MRI, which is used infrequently. You can also use nuclear imaging with a technetium isotope, but I've never seen that before. So if your patient starts fitting a lot of these criteria and say has a clear-cut history of alcohol use disorder or a long history of hepatitis C, this patient may not need a biopsy, and you can just go on to diagnose them with cirrhosis. Okay. So my patient representation here is that we have a 62-year-old man with cirrhosis due to hepatitis C and alcohol use, who's admitted with large volume ascites due to decompensated cirrhosis. Do you guys agree with that? Does that sound good? Okay, so we're gonna get into a little bit of how we work this patient up in the inpatient setting and what are all the things that you guys should think about when you admit a patient with cirrhosis. So this patient has decompensated cirrhosis, right? So when you look at notes that somebody's written for cirrhosis, there will be like certain things that everyone documents on. And so these are the domains that I find helpful to document on to provide the patient with comprehensive care. So we're gonna think about spontaneous bacterial peritonitis. We're gonna think about their volume status, and I won't read through them, but we think about these domains when we admit somebody. And so let's go through these, and we'll think about these in the context of our patient here. So the first question you have to ask yourself when someone comes in with decompensated cirrhosis is, why did they decompensate, right? Don't just accept that they're decompensated. You have to look for a cause. And so why do you guys think cirrhosis decompensates? He was drinking. Okay. He was telling you that he hasn't drank in the last 2 years. So what are some things that you can do to figure out if he's drinking or not? Yeah, you can do a blood alcohol level if he just very recently drank. What else? A PEth, right? Yeah. So it's the phosphatidylethanol, which is the A1C of drinking. Transplant clinics will often use it. It's PETH, PEth. And that's a level over the last 3 months of how much the patient has consumed alcohol. And the higher the number, the more alcohol they've consumed. So that's something that you can order. It takes a very long time to come back. So in this case, it would just be helpful to, encourage the patient to be as honest as they can with you so that you can provide them with the best care. But alcohol use is one. Infection, yes. Bleeding. So bleeding is how people decompensate, right? Like decompensated cirrhosis, they present with bleeding. So I wouldn't necessarily call that an etiology of decompensation. But that's neither here nor there. And then medications, drugs, yep. More specifically, non-adherence to medications that they've already been prescribed. So non-adherence to lactulose can cause decompensation of encephalopathy, and then non-adherence to your diuretics will cause volume retention. And then what else? There's one big area. What makes you retain water? Sodium, yeah. So quite often patients who present like this are eating a lot of sodium, and so you have to start counseling these patients on their sodium intake. So those are the common reasons. But infection is really a big one. And then one other one that I added here is, does the patient have a portal venous thrombus or something like Budd-Chiari, right, which can cause rapid accumulation of ascites. And so once you think about that, for those of you that have been on the liver team, the hepatology team over at university know this, but for us who are taking care of patients at other hospitals, it's really important for you to look for infections. So our hepatologists actually want you to do sort of a full infectious workup, so chest x-ray, urinalysis, and then we'll talk about what to do with their ascites here in a second. But also for most patients, consider a right upper quadrant ultrasound with Dopplers if they haven't had one in really, honestly, like more than a week. And so if somebody gets admitted like every other day with ascites and you're doing paracentesis every other day, that may just be that their disease has progressed. But for most patients, it's valuable to have a right upper quadrant ultrasound to make sure they don't have a thrombus. Okay, so we're gonna get into SBP a little bit, spontaneous bacterial peritonitis. And so in a decompensated patient, any patient that you admit that has any amount of ascites should get a diagnostic paracentesis. And most hepatologists argue that this should occur every time, and this has become my practice as well. And so if I, with an ultrasound, can see a pocket that I can tap for even a diagnostic sample, then I'll do that and I'll send that off. Quite often our ED colleagues have already done this for us, and so it's really helpful when they do that. So when you get a diagnostic para, what studies are you going to send on it?
Like cell counts.
Cell count, yep.
Protein.
Protein, yep. Total protein.
Albumin.
Albumin.
And then maybe gram stain.
Yeah, gram stain and culture. Yeah, good. So those are what I had. So when you order, when you send the fluid down, which in most of our hospitals, a physician has to walk it down to lab, you should order an acetic protein and albumin, and hopefully you've got a LFT, so you have a total protein for the body, cell count and differential, and then along with that, a culture. And there are two reasons why we're ordering these studies. The first reason is that we're trying to diagnose an infection, right? And so SBP is diagnosed if the patient has more than 250 PMNs in the ascites. Just beware that at some of the hospitals, the way they report this is they'll give you a total white blood cell count and a percentage of PMN. So you'll have to do some math and just multiply the total number by the point of whatever percent PMNs were in there. And then if they don't have that, but look really ill or are septic, you can still treat them for SBP and then await the culture. If the culture turns positive, then they have SBP and you treat them with antibiotics. If they have these PMNs, then they automatically have SBP and you start treatment. And just remember that treatment is with high dose cephalosporin. And so usually we'll use ceftriaxone 2 grams BID, so high dose. Cool, and then you can narrow based on the cultures. And so then why did we get total protein and albumin? You don't have to get them in a patient that has a surefire diagnosis of cirrhosis, but often patients will present to you with new ascites, in which case getting the serum albumin, the ascites, albumin, and protein are helpful. And this chart, which I refer to often, can help you differentiate between the etiologies of the patient's ascites. And so in this patient, I didn't give you the numbers. This is a patient I took care of like a week ago, had a SAG of greater than 1.1 and an acetic protein of less than 2.5. So it was pretty obvious that his ascites was from his cirrhosis. Okay, so moving on. So we've decided that this patient did not have an infection because his PMNs were like, his total white count in there was like 33. So there's no way you can have PMNs of 250. And it was obvious that his ascites was from cirrhosis. So then next problem is your volume status. So this patient's overloaded, right? Both with ascites, and he had some edema that you noted. So do you guys think that his home dose of Lasix is sufficient to manage his volume overload? No, everyone's shaking their head. Tell me what you guys would choose for him.
There's like I forget the ratio, but cirrhosis to spironolactone.
Yeah, nice. So for those of you who didn't hear that, so typically to treat volume overload in cirrhosis, we use this Lasix and spironolactone combo in a ratio. So I looked into this and I asked myself, why do we use these two medicines? And actually there's data that supports that spironolactone alone is just as good as the combination, but the problem that you run into is hyperkalemia. And really it's for the hyperkalemia reason that you typically tend to use the combination. And I think now it's just become sort of a norm to use the combination. And so people will use Lasix to Spiro in a ratio of 2 to 5, okay? But if you were going to start a patient on monotherapy in the outpatient setting, then start with spironolactone rather than starting with Lasix is what the data suggests, which is not what I was doing. Okay, so then for him, we're gonna increase his Lasix to 40 milligrams and we're gonna start spironolactone 100 milligrams, and that somewhat fits the ratio. And you'll follow his potassiums just to make sure that you don't need to tailor either medicine one way or the other. All right.
About his sodium? Because he was already
Okay, great. So I'm not going to get into the sodium here, but why do you guys think he's hyponatremic? Fluid overloaded, yeah. So, you know, hyponatremia is a whole talk on its own, but usually it's a fluid status problem. And so with this patient being volume overloaded, so hypervolemic hyponatremia, his sodium will likely get better when you diurese him, meaning when you get rid of that extra fluid. Yeah. Okay, so the next problem is coagulopathy. So this patient had a platelets of 57 and INR of 1.4. So are you guys gonna use pharmacologic VTE prophylaxis in him, so heparin or Lovenox? Yep, some people say yes. Does anybody say no? Okay, for those of you who said yes, how did you decide on that?
representation of the coagulopathy of a patient with cirrhosis.
Okay, yep, INR is not an accurate representation of how coagulable the patient is. What else?
Well, his liver is functionally not in the anti-inflammatory, so he's at risk for getting diseases.
Great, yeah, his liver's not making the stuff you need to bust up clots, etc. So you're at higher risk of clotting. Great. What about the platelets though? They're so close to 50. And we don't anticoagulate people who are platelets less than 50. So the reason I ask this question is because I've asked myself this question thousands of times, hundreds of times when I've admitted people with cirrhosis. And it's really complicated because like you guys point out, so these patients are at both risk for bleeding and hypercoagulability. I've had patients in the ICU that, like, as an intern, I stood at bedside holding a sandbag over their central venous line because it kept bleeding and like had to hold pressure all through rounds. And so these patients can bleed quite a bit, and some people you can't stop their bleeding. And then some people have a history of hypercoagulability because of the reasons you said. So they're deficient in protein CNS, and data suggests that patients who have albumin less than 1.9 are worse off. These patients are already at 1.7 times the risk of VTE than people who don't have cirrhosis. You guys are right. This is a really a balance. And what the overall sort of consensus is let's just treat cirrhosis as if the patient didn't have cirrhosis. And so most people advocate for using the Padua prediction and using this to help you determine whether the patient needs anticoagulation. If this patient had a history of a portal venous thrombus or a PE or something like that, they automatically get a 3. And so thinking about people that have had previous VTEs, especially in men who are at higher risk for recurrent VTE, I'd be more inclined to use prophylaxis. So for this patient, his Padua was less than 4 and he was pretty ambulatory. So we just recommended that he ambulate because we were worried about his platelets being so low. Okay, so then next up is encephalopathy. Do you guys think that this patient is encephalopathic? Yes. Why? Yeah, awesome, Lila. So when it comes to encephalopathy, there's both covert and overt encephalopathy. So don't miss the covert signs, which are most commonly an altered sleep-wake cycle or poor sleep or insomnia, decreased attention span, and which often manifests for these patients as memory loss. And so they'll complain that their memory is just not as good as it used to be. And so they are starting to get encephalopathic. And then the grades go on, and in grade 2, commonly you see hysterexis, grade 3, somnolence, and then grade 4 is a coma. So I think most of you know that we typically use lactulose in patients to treat hepatic encephalopathy. And so just a couple of papers that I looked into. So recently there is data that suggests that polyethylene glycol or Miralax is just as good as lactulose. Lactulose can cause a lot of bloating and gas and like abdominal pain. So if somebody's already having those symptoms, consider using Miralax, which is just as good. But the data does suggest that the combination of lactulose and rifaximin results in a quicker resolution of encephalopathy. So if somebody's sort of grade 2 or above, I do consider starting them on both of those treatments. Do you guys have any questions about that? Rifaximin, you often run into like insurance problems, and so people want to try lactulose before starting rifaximin. And this I just mentioned that the combination is better. All right, so for this patient, we started lactulose daily. And remember that you don't have to take lactulose like 2 or 3 times a day. All you need to do is take enough to have 2 to 3 kind of loose bowel movements per day. To help ammonia excretion. And so if it works for them to take just once a day, then that's what they should do. If it's really bothersome for them to have this many bowel movements, you can consider doing every other day, and that'll be better than nothing. So the last few problems we'll sort of move through more quickly, and one of them is varices. And of course, variceal bleed, GI bleed, and our patients with cirrhosis is a whole talk on its own. But just to think about varices, especially when the patient is here without a GI bleed, is to make sure you look into their chart to see when their last EGD was. For most of these patients that don't have varices, EGDs are recommended every 2 to 3 years. Most patients that I've seen need EGDs 1 to 2 years because they have some amount of varices. And then we often use beta blockers, like this patient was on propranolol to help prevent variceal bleeds if they have varices. And for anybody that doesn't know what varices look like, it is these columns. So these are the veins that are sticking out in the esophagus. Cool. So his last EGD was 9 months ago. He only had small varices, so continue his home propranolol. You're good to go. His heart rate was 72, so the propranolol is not causing bradycardia. Okay, so then the summary of your plan is that this patient has decompensated cirrhosis. I calculated his MELD for you, which you can do on a variety of online calculators, and his MELD sodium was 21. And then the one that I didn't mention, there are 2 I didn't mention, is one is hepatitis C screening. And so these patients should get yearly imaging, which is usually an ultrasound. And if they have lesions, forehead, hep C, or HCC, then they need a triple phase liver study. And then making sure that you're thinking about whether this patient has been at least evaluated for transplant or somebody has considered transplant in them. In my acute liver failure talk, which you guys can find on our YouTube channel, I talk a lot more about how these patients go through the transplant process. But making sure that they've at least heard the word before and get them hooked in with the GI clinic so that they're considered for transplant, which is the only cure for cirrhosis. And then I wanted to talk a little bit about health disparities surrounding cirrhosis. And so some of these statistics were shocking for me to look into. So hepatitis C is twice as prevalent in Black patients. And the referral rates for treatment for hep C are much lower in the Black and the Latinx population than the white population. So making sure that you're thinking about referring people for treatment anytime you know that they have Hep C. Black and Latinx patients are less likely to receive transplant, and so the odds ratio if you're Black is 0.3 and Latinx is 0.4, so less than half, and those are really bad stats, right? So again, in the inpatient setting, when somebody's sitting in front of you with a massive variceal bleed, transplant is the last thing on your mind. But if you make your assessment and plan section the same every time and either template it or make it a dot phrase, then this is something that you won't forget to think about and bring up with the patient, at least on discharge. And then finally, we need to make sure that we're using culturally sensitive and patient-centered language. So this patient, who'd actually had cirrhosis for like 10 years and has seen GI before, was there and told me that he has no idea what's going on with his body, which either makes me think, you know, he has more encephalopathy than I think he does, or that people just haven't taken the time to really sit down and explain to him what's going on. Thankfully, he stopped drinking 2 years ago, and so he's doing some things really right, but anytime you see this amount of progression with ascites, that's actually a really bad prognostic sign. And so you have to counsel him on sodium intake, making sure he takes his meds, and making sure that he's seeing GI regularly. Let's see. What are our thoughts on once decon, maintain label as decon source? Miranda, I am not sure. I didn't really think about that too much for this talk. Usually when I do my patient representations, I will say that this patient has hepatitis C or alcohol-related cirrhosis, and I'll say like in parentheses, write down all the ways in which they've decompensated before. But I guess, you know, if they always have ascites and they're always somewhat in a state of decompensation, so perhaps you can say that for people that are like really end-stage disease. Okay. Cool. So just to summarize, we talked about diagnosing cirrhosis, which is mostly done by history labs and imaging, but biopsy is the gold standard. When you're presenting these patients, do that in the same way each time so that you get better at taking care of these patients. I'm still working on that. And then some inpatient management pearls are that considering diagnostic paracentesis and an ultrasound in every patient that's admitted. There are exceptions, but these are things that you should be thinking about when you admit these patients, even if it's overnight. And then I wanted to give you guys some self-directed learning topics. So look into when one would use primary prophylaxis for SBP, because there is data around that. Look into what is hepatorenal syndrome and the implications of it. And then management of SBP. Our patient didn't have it, but if he had it, what would you do? What antibiotic would you use? What is an albumin challenge? And so look into some of these things to enrich yourselves. Cool. Reminder of our awesome YouTube channel. We want more than 21 subscribers. Get on it, y'all. And then if you wouldn't mind filling out just a 4-question survey, it takes 30 seconds to help me figure out what other lectures you guys want to see and what I can do better. I'm happy to take any other questions, comments.